Andrew is currently a junior in the College of Arts and Sciences and is originally from New York. He is studying to be a biology major with a medical humanities minor. Andrew also worked as a research assistant for the Walsh Professor of Bioethics. So let's all give it up for Andrew.
All right, so good evening, guys. Nice to have you out here. So tonight I'm going to be talking about Ebola. So Ebola is a zoonotic virus. Does anybody know what zoonotic means?
Jump from like animals to humans.
All right, I'm happy you were here. So, Ebola. Ebola has been a fear-provoking experience for all of us. We look at our media, we look at the headlines every day. It's been something that's been spreading. Greg Mittman in the New England Journal of Medicine recently had a comment saying that fear spreads faster than Ebola. And this is true. So, look at this chart. We have a projection from healthmap.org. Healthmap.org synthesizes data from the World Health Organization as well as social media reporting. And they're saying by the end of this year, we will have upwards of 24,000 cases. This is an estimate, obviously. But this fear has not surpassed the healthcare professionals as well. They're dealing with a crisis that's escalating rapidly, but they're also lacking tools to deal with the situation. They're dealing with this dysfunctional public healthcare system over in West Africa, in Guinea, Sierra Leone, and Liberia. Furthermore, go to the next slide. We have 2 vaccine candidates, both of which have not passed phase 2. And I will explain what phase 2 means. But this means that we do not have a vaccine or a medication to deal with Ebola directly. Furthermore, a phase 2 trial, which will be occurring at the end of this year and in the first quarter of 2015, will not happen in any African Ebola patient. It will only be used in U.S. healthcare professionals going overseas. So we have a crisis. We have an escalating case total. We have no tools to deal with the situation. We have a dysfunctional system where we can't move resources. We have a desperate situation. So what do? Do we use desperate measures to deal with this desperate situation? So, how do we know that something works? How do we know that a medication is effective, it's safe, it doesn't kill us? How do we know this information? We use a clinical trial process. This is a comparative analysis. I'll get into what a comparative analysis is, but this is our method for finding this information out. Next, I'm going to be talking about convalescent serum therapy, and I'm not talking about your local nursing home. I'm talking convalescent. And convalescent serum therapy is a plasma transfusion, and it has become a very popular methodology for dealing with Ebola patients. And I'm going to get into that more. And I'm also going to touch on the World Health Organization, and they convened an ethicist committee, and they came to a decision on plasma transfusions and the use of those plasma transfusions for the treatment of Ebola patients. And that decision did not take into account scientific evidence for convalescent serum therapy as well as judicial precedent. So, we have clinical trials. How do we decide something works? We split into a group that receives the treatment and doesn't receive the treatment. That's the simple, basic premise of what a clinical trial is. So this was done in 1721 in Boston during the smallpox epidemic. Cotton Mather, who is our infamous, or I should say famous, physician and theologian that many of you know from your history classes, he tested out a process that he learned from his African slave who, using a cowpox sore, was able to inoculate another individual, giving them immunity to smallpox, a similar virus. So we wanted to test this out. How does this work? So we split it up into 2 groups of individuals. He evened the 2 groups out according to the population demographics, and he tested this out. And he found out that the group receiving the treatment had a lower mortality rate. This was our first example of a clinical trial process in the United States. So what do we do today? We have the Federal Drug Administration, which was established in 1933 under the Food and Drugs and Cosmetics Act and has absolute authority to determine whether a drug is approved for use or whether it is not approved for use. Simple. And they use this clinical trials framework. So a drug comes as a proposal and has to be shown in a preclinical stage. This is using an animal model. That animal model determines safety, does it kill the animal, and effectiveness, which is efficacy, does it work? Then we move into a human trial, which is phase 1. Phase 1 is a small study dealing with drug metabolism and safety. From that information, we move to a phase 2 trial where we have a small group with 100 to 300 people, and we're testing for effectiveness. We do this in a small group because if it's not effective, we want to make sure that we minimize the impact. And then phase 3, which is upwards of 3,000 patients, and that determines the efficacy of a drug. So it's so important to uphold this methodology that in 2001, there was an important case, Abigail Lyons versus von Eschenbach. And in this case, a patient, Abigail Burroughs, who was suffering from colon cancer, she wanted, well, her father did, wanted her to access a phase 1. We've just established that it's safe. We have not established whether it's effective, but there's hype about these drugs once they reach phase 1. Erbitux is a drug for treatment of colon cancer. So in that study, the Supreme Court overturned a decision by the DC District Circuit Court and stated that this procedure, this clinical trials framework, was so important to the public interest in maintaining the determination of efficacy of drugs that they established that we need this and we cannot have people accessing these drugs before they've completed the entire process. Why? It's a simple case. If we are allowing people to access at phase 2, we won't have any subjects to fill our phase 3. And that's important for the public to have drugs that have passed through all of these stages. If we didn't have this, you wouldn't know whether Tylenol worked. So, very simple. Convalescent serum therapy. So before I get into convalescent serum therapy, I have to go over some basic information about what immunology is. So, active immunotherapy, it's your flu shot. You're introduced to an antigen, you receive this antigen into your body, and you produce antibodies. This is your defense mechanism for recognizing pathogens and removing them from your body. That's different from passive immunotherapy. Passive immunotherapy is the transferal of antibodies from one subject to another subject in the hopes that that will confer some sort of benefit. Doesn't always work in all cases. So convalescent serum therapy requires two things. It requires what's known as an apheresis machine. An apheresis machine takes the plasma that is donated from an Ebola survivor and it centrifugates it, removing the parts that we want. So we don't want the red blood cells, we want just the white matter, which is immunoglobulins and antibodies that are specific to the pathogen we're dealing with. So, all of our patients that have come to the United States have received this therapy. It's interesting to think, what is the scientific evidence for this therapy? We're obviously giving it to everybody. Does it work? The scientific literature on this is inconclusive. In a study done in 2007 at the National Institute of Health in Maryland, they took 8 monkeys, and they had 3 monkeys that had previously been exposed to Ebola, had survived Ebola, and they had verified that they had antibodies for that virus. Then they followed the exact same procedure of convalescent serum therapy, that's a protocol for blood transfusions, and they inserted that blood basically into 8 monkeys. It's interesting to note, all 8 of those monkeys died. They did not receive supportive care. Just remember this point. They did not receive supportive care. They verified that they did receive the antibodies. So the antibodies are present. They received through a passive method, and it does not basically save them from the Ebola virus. So the hype for plasma transfusion methodology comes from a study that was done during a Ebola epidemic, the most recent one from now, in the Democratic Republic of Congo, where a group of doctors was dealing with this situation, and they transfused 8 women, and they noted that all, or a good amount except for one, had all survived. All of them survived. You would think that this case study is just as remarkable as the study that I just commented on. However, they did admit within their document that these patients received superior supportive care. Superior supportive care. Supportive care, in the basic sense, is IV and hemodynamic, or your blood monitoring. This is basic care, conventional care, that any patient will receive in a United States hospital. They receive superior care to the standard patient in the DRC crisis. So, the World Health Organization. The World Health Organization has been pressured constantly by the other world's humanitarian organizations. They come to them and they're saying, what is the answer? What do we do? How do we treat these patients? I don't have any tools. We don't have enough supportive care capacity. And we're stuck. And we're stuck in a situation we don't know what to do. The World Health Organization on September 26th convened a meeting of medical ethicists to decide whether the provision of experimental therapies that have not gone through the entire FDA approval process, whether it was ethical, it's an interesting term, but it was ethical to provide that therapy. So furthermore, they supported this by distributing a manual for physicians on how to proceed on these plasma transfusions. And within this manual, they stated if it was biologically plausible, not proven, plausible. And furthermore, they said the byproducts of investment would be beneficial in improving healthcare infrastructure in these 3 countries. The byproducts of investment would be beneficial. Byproducts of investing in a therapy that has no grounds for efficacy. So now we have made the decision to go against the judicial precedent that I established through Abigail Alliance. There's cases that have gone into the past, that's the most recent one. And we have now moved forward on providing a therapy in a desperate situation to patients, and essentially we're setting ourselves back, and we're providing something that doesn't work, and we're basing our argument on it may work, and that if the byproducts of blood transfusions, they would be beneficial. I have 2 points on the byproducts of investment. 1, countries in Africa, especially in West Africa, have a high prevalence of HIV transmissions in their blood banks. If we increase blood transfusions to a level that is significant enough to deal with the 24,000 possible cases that we will have, we are going to be increasing the transmission rates of hepatitis C, hepatitis B, HIV, and any other bloodborne viruses in these blood banks that are not screened like they are in the United States. And furthermore, in order to have a pool that is large enough to deal with the case total, you would need survivors donating blood at an increasingly high level. And I want to return to the one last comment on supportive care. And that supportive care may be the variable that may be the most important treatment method for Ebola patients. So I want to conclude with 3 points. The first point is to question with boldness. I want all of you to leave here with a feeling that you can go and act as a scientist on your own and question information that you receive in the media, as well as any of these regulatory agencies, and do the research on your own and figure out, does this work? we are rational human beings, just as rational as those who are in power and make these decisions for us. We can question them, and we can decide for ourselves, is this efficacious, based on data. Right? An interesting podcast in JAMA, or Journal of American Medical Association, from the CDC director, Thomas Friedman, said, we must base our decisions on data. Are we basing our decisions on data? I'll leave that up for you to decide. My second point is prevention versus reaction. This epidemic has reached this scale because of infrastructural inequities that have been present within these three countries in comparison to the westernized countries. So, prevention. Liberia, it's an interesting fact, was a freed slave colony with the United States. We've let these three countries deteriorate so far, and we've not held up to our responsibility of providing basic supportive care capability to these nations. That is resource-based information. And now we're reacting. Now we want a vaccine. Now we want a convalescent serum to save ourselves from this virus while we've been lacking our responsibility all along. And my last piece is the human factor, is to think deeper about how our decisions affect people. And this was a recent portrait series in the New York Times called Braving Ebola. And I want you to think about the decisions that you've made and whether those decisions are based on data and whether we're giving people a drug or a medication that has passed the highest level of our rational framework based on data so we can provide the best possible therapy for the Ebola patients and epidemic patients in the future. And this is an important topic, and this ties in with every other topic within the bioethics realm. Thank you.